Department of Public Health seminar series presentation. So the NDSU Department of Public Health has roughly twice a semester of seminars of this nature. Although most of the time they're only offered virtually, just for convenience, but we serve the people across the state. But once a year, we'll have an in-person event like this. And so today, having Dr. Lance Presser join us is really special, being homecoming, being together. And it's really wonderful to see a large crowd here in person. And I also want to welcome the folks who are online too. And I hope that signal and the image is all working well too. So we'll start with presentation, and then there'll be time for Q&A after. So feel free to get questions. There will be time at the end for Q&A. It's really a privilege today to have Dr. Lance Presser with us. Lance is a virologist who began his career in microbiology here at NDSU. So he's coming home. He received his bachelor's degree in biotechnology and microbiology in 2005. And then he received his master's degree in infectious disease microbiology from the University of Pittsburgh Graduate School of Public Health. He received his PhD in microbiology and immunology from the Rosalind Franklin University of Medicine and Science in North Chicago in 2012, studying hepatitis C virus, host cell interactions, fibrosis, and hepatocellular carcinoma pathways. Following his PhD, Lance worked at the Milwaukee Public Health Laboratory, and there's students here wondering, what do you do if you study public health? Have your antenna up. Here are opportunities. And then he also worked at the Tripler Army Medical Center. He was suffering in Hawaii. How long were you there?
A little.
Okay.
Not long enough.
Yeah, that was a suffering point. And then he joined the U.S. Centers for Disease Control and Prevention Viral Special Pathogens Branch. At the CDC, Lance worked in biosafety level containment. That's BSL for those who are less familiar. So BSL 3 and 4, 4 being the highest level containment. So that's really high priority, high risk research that he was involved in, primarily on hemorrhagic fever research and diagnostics. And that word, if familiar, would be synonymous with Ebola, which was the outbreak in 2014 and 16, when he was then deployed to West Africa as the US CDC diagnostic laboratory team lead for 3 teams. And I'm sure you're all old enough to remember that time. So thank you for your service at that time. After the Ebola outbreak, he stayed in Africa and built capacity systems in countries of Sierra Leone, Liberia, Guinea, Nigeria, and Uganda, all countries from which our program has students. In 2020, during the SARS pandemic, Lance was hired by the National Institutes for Public Health and the Environment in the country of the Netherlands, that's Holland, as a virologist. In the 5 years that he's worked at the National Institute, he has numerous publications on a wide range of virology topics. He's also involved in or coordinating 3 European Union funded programs and helps coordinate the WHO Collaborating Center for Laboratory Preparedness and Response for High Threat Pathogens and Biorisk. I'm adding, if the Master of Public Health program existed at NDSU in 2005, I'm sure he would have pursued it. And if you don't believe me, I can assure you he would have, because since we started, he's been a generous donor to the program and to the university, and currently serves on the NDSU Public Health Advisory Board, for which we thank you for your service. Thank you for your presentation, and we look forward to hearing from you today.
Thank you very much for that very nice introduction. Because the MPH program did not exist yet. I finished here in 2005, and the School of Public Health didn't exist yet. So I went to Pittsburgh instead. My PhD in Chicago. But it is, as always, I think this is now my 3rd year, 4th year coming back for advisory board meetings. So it's always nice to be back. Mark gave us really this introduction about kind of my wanderings career-wise, but I want to highlight each of the steps along the way really has been laboratory diagnostics and lab system strengthening. Those are really the 2. So the Netherlands is a very small little country that most people haven't visited. So I thought I would start by sharing just a bit of background about my new home. thought this might be familiar to a lot of you. I mean, this could be pretty much anywhere in the Red River Valley, so thought that would be a good introduction. Similarities, they're both very flat. Netherlands is extremely flat, lots of agriculture, and actually has the closest language to English in the north, which is Frisian. They separated a while back. It wasn't that long ago that you could just kind of walk across to the UK. So kind of interesting. Differences, I think the number one thing is population density. Netherlands is about 1,400 people per square mile. North Dakota is 11. So that quite significant, and you will notice it if you ever come to visit. With the languages being quite similar, and with the some of the historical settlements that happened here in the US, there are quite a number of words in English that do originate from Dutch or from the Netherlands. I put some fun ones up there just for trivia. So now when you go to trivia night, maybe you get lucky and one of them is about the Dutch language. And like a good alum, I have maintained my NDSU stickers on my bicycle. I have yet to see another NDSU alumni walking around, but one of these days it's going to happen. So the talk today is a lot about laboratories and what they do and how the networks operate and ways to build and strengthen systems and to keep these systems resilient and robust. So what do public health laboratories and specifically microbiology laboratories, what do they do? So, you know, this is kind of a broad list, but microbial diagnostics, right? So there's typing and strain identification. This is going to be important for things like influenza, right? H5, H3, H1, your hemagglutinin types, and some ways this can alert people to things like zoonotic influenza and jumping species or different shifts that happen within the virus. Surveillance is another important aspect, measuring incidence and prevalence, doing passive, active, or sentinel type surveillance. These are common mechanisms just to observe what's happening in the population. Outbreak investigations are also key. So things like measles or foodborne illness are going to be common things done in these laboratories. Monitoring treatment effectiveness. So if there's some new treatment, antiviral, monoclonal, antibiotic, something like that. Often what's done is to observe and make certain that those treatments are working properly or not. Developing new diagnostic tools. But most recently, this is really probably SARS-CoV-2, right? Anytime you have a new virus, we need new diagnostic tools. But we also do this from time to time if there's certain mutations in viruses, bacteria, new platforms to do diagnostics. This is sort of an ongoing process that public health labs play an important role. Investigating disease mechanisms, developing vaccines and treatments, informing public health policy. So for public health policy, since this is a public health event, you know, things like when does West Nile season starts, if there's hotspots for mosquitoes, ticks, we saw recent things like SARS-CoV-2, all the things that happen around that, but things like mpox, measles outbreaks, meningitis in certain schools, those are going to be common pathogens, diseases, events that kind of drive or should drive public health policy and communication and notification, things like that. And of course, training and education. I didn't quite know where to put this slide, but I wanted to include something like this so that people are a bit familiar with the differences and similarities between the European Centers for Disease Control and Prevention and the US CDC. So the European version of the CDC is a bit newer. It's also quite a lot smaller. So the construct was such that all of the countries that make up the EU all have their own national institutes for public health or some large national reference laboratory, along with their university labs or the big hospital labs or whatever. But those are really your expert labs. Those are your reference labs for all the pathogens, all kinds of things. The one in the Netherlands where I work is also, it includes the environment. So it's the National Institute for Public Health and the Environment, and that really covers everything, really. It's water, it's livestock, agriculture, it's air, noise, et cetera, along with our laboratories. So that's a bit the general construct. And then what the Europe CDC or ECDC did was to sit on top of that and to sort of act as the EU-wide collection center for all that. So they don't have their own laboratories like the US CDC does. They don't have nearly the number of staff, right? They really act as just a focal point for all the different country level institutes. And thus, their mandate is a bit smaller, and therefore their budget is also a bit smaller. So with laboratory networks, with these systems, where are we post-COVID, right? And so there's a couple of quotes here by some of the big oversight committees globally and in the US, basically saying that, yeah, we had some things right, we had some systems in place, wasn't quite good enough. So why discuss these laboratory networks now? And I have a couple different, I'll try to have a European Union global context, and I'll try to have a US context. So the EU specifically is changing their structure. It's a very large reorganization that I don't really like that much, but that's my personal opinion. And in the US, you're seeing a bit of reduction and some shuffling as well. WHO's cutting its budget, USAID is going away. And so that's a lot of programs and dollars and people. And it's a lot of global vision and sight that we're kind of losing on some of these pathogens. I included this little graphic, and it might be a little difficult to see. And I don't, the slides are going to be shared if possible, or if people want to see them.
Awesome. Yeah.
Great. There's also a link, so you can just go see this. This is our old network. So this is a network that we coordinated for many years for ECDC, and it's really this emerging diseases network across Europe. So again, all these reference laboratories have this network where if there's any new emerging rare pathogen, what you have is you have who has the expertise, who can do these tests, who can handle these samples, points of contact, and all of the systems that go with those. So the legal systems for sharing samples and patient data across countries, the financial systems for shipping samples, running diagnostics, all those little legal and administrative things that can cause problems. All of that was already established, and that really helped build this network and to make it very responsive. And I'll talk about that a little bit later when we get to some of the experiences slide. So as I mentioned, for the US, again, it has been something that's been building up, right? We had a number of years, the Ebola outbreak was a little over 10 years ago. There was a huge increase in money and funding for the Ebola response. That was followed by Zika. That was followed by SARS-CoV-2, right? So we've had quite a phase of a lot of money and a lot of buildup in the system. This is now in decline, right? So you're talking about pretty serious budget cuts, and a lot of that funding goes to directly support the state and local health departments and hospitals. So you're starting to see a pretty large shift of money and people and stuff and all that out of the US and global system. So I wanted to highlight a few networks that are kind of at risk, that are interesting, and maybe these will not completely go away. Maybe they'll change into something else, but there's some really neat programs that are at risk because of this money going away. One of them is the Advanced Molecular Detection Program. This was a big program run through the CDC to sort of integrate and build sequencing and bioinformatics networks in the different states. And you can see kind of the investment numbers for some of the local states, the surrounding states, Minnesota being a bit higher because it was one of the hubs that was highlighted, and it was one of the principal investigators for this network. But this is going to be really important from just an identification, right? Like if there's ever a new outbreak of anything, sequencing has now progressed to the point where this is a good surveillance tool in some cases, but it's also going to be really important for all kinds of, tracking foodborne illness outbreaks, any type of some of the discussions around the zoonotic influenza situation that's ongoing, right? So this is something to keep an eye on, or to see how this shifts, or if it goes away. There's a global immunology and immune sequencing network. It's a Global South network, and this is even bigger. This isn't just emerging diseases or zoonotic, it's also things like cancer and some of your more chronic illnesses as well. And this CREED network was also something that was quite important, and this one is for now stopped, but this is a really interesting, more research network. This was really a lot of going into the field and identifying new pathogens, and then doing some pretty intense analysis in a laboratory to determine whether or not these had zoonotic potential, how they behaved, developing new diagnostics, developing new antibody therapies or antivirals against these types of viruses. And for now, this is stopped, so that will be interesting to see what happens. But that was a very large network across a large section of. So, laboratory networks. The reason I think that these are so important, it's sort of a simple idea, right? Like this idea of, let's all just form a team and do stuff together, right? It's such a efficient way of doing things if it's done correctly, right? The amount of, the pooling of resources, not every laboratory has to have a test for Ebola, right? Like, so this idea of being able to select a group, whether it's national or regional or international laboratories together, and build the systems in an efficient way, the funding and legal and data and sample sharing and all these things. It sounds quite simple. It's really not a earth-shattering idea in any way. It's just very rarely done well. And I think when it is, it's worth noting because it can be really efficient, right? You can do a lot of things for less money, which is important nowadays. You can use less people, right? You don't need, not every laboratory needs, 100 experts. It's just a very robust and resilient way to do some of this public health work. I put this figure in here. This is a kind of an old figure modeling what an integrated laboratory network does, and it's basically kind of 4 pillars. And this is primarily like imagine this is at like the country level or a small region. And the first level is really just your community centers, going to districts, going to national, going to like the main top reference laboratory. And that's kind of a general model that like if CDC, if the US CDC goes into a country like we did post Ebola and wants to really build laboratory capacity and build a country's public health infrastructure, this is sort of the model that they use, right? You go from the community and district hospitals and clinics into the more larger national reference lab or national public health institute. Sometimes it's a big national hospital. We have a very large hospital, like research hospital, university research hospital in Rotterdam called the Erasmus Medical Center. They actually have more advanced laboratory space than the National Public Health Institute does, basically just because of timing, right? Our building is quite old. It was built post World War II, and theirs was built only 15 years ago. So they currently have the best labs. And so we work closely together because we don't want to spend $50 million building a new laboratory for now. It's little things like that can be done if you get over the initial legal and financial and territory hurdles. And I think that's often a lot of the problem. What I do want to point out too, what's missing here from this is also the horizontal modeling, right? When I earlier talked about the emerging virus network that we coordinate across Europe, those are typically it's like a horizontal network across that top level 4 reference lab pillar or pinnacle or whatever, right? So all these labs at this level are also networked together. So you have a vertical network within a country or within a small region, then you have a horizontal network across all these different countries, which is also very helpful. So I just want to kind of give you an idea what these networks do from the beginning to end. So this example, this is a previous slide, but this example was when Zika happened, right? Was when the Zika outbreak happened. But broadly, this applies to all the other most recent outbreaks, whether it's SARS-CoV-2, mpox, some of the other mosquito diseases, anything like that. The network kind of responds in a similar way each time. So the first thing that happens is scientific support. So you have this whole network to call on, right? You have maybe 40, 50, 60 institutes full of experts in all these different countries. So the European Union says, okay, who's the expert? Who knows what? What are we looking at here, right? And that's when, whether they are real experts, right? Whether they've actually done the research or whether it's the closest thing, right? So when SARS-CoV-2 happened, right, no one was a SARS-CoV-2 expert, right? But there was a SARS-CoV-1 and there was a Middle Eastern respiratory syndrome, another coronavirus. So you call on the coronaviruses and they start looking into how to do stuff or what needs to be done. We can update with situation reports, so the entire country is aware, but also the physicians and all the public health institutes at all levels are aware. You can start doing assessments of laboratories to make sure all your diagnostics are working properly, and that's through the whole chain, so that the physicians are sending the proper samples, that the labs are doing the proper tests, that the results are being reported properly. And then that feeds into training and capacity building and data sharing and reference testing, right? So this is kind of a holistic cycle situation going on each time an event like this happens. But there's a lot of, again, there's a lot of, the lab part is almost the easy part, right? It's really the legal and financial and data sharing and patient data and things like that that constantly are difficult, especially when you start talking about laws in 30 different countries or 40 different countries, right? So with regard to scientific support, these can be reviews, fact sheets, rapid risk assessments, peer-reviewed publications. These can look and function in a lot of different ways. Primarily, these fact sheets are really important for in a lot of mostly they're aimed at healthcare workers, right? Physicians, nurses, things. It's really to drive awareness so that they're looking for these types of diseases so they can send the appropriate samples. that's not always easy, right? If something is new or something is rare, oftentimes the physician maybe doesn't think of it right away. That means the lab doesn't get the correct sample or doesn't get a sample at all, right? So really this is meant to drive awareness at all levels of the public health chain. One of our focuses, and this is a very laboratory geared idea, is this quality assessment of diagnostics. And I'll talk about this a little bit more when we give the SARS-CoV-2 experience. But this is very specific to laboratories in a lot of ways to make sure the diagnostics are performing properly. And that really takes a lot of detail, really takes a lot of effort and a lot of communication with each of the individual labs doing these tests, because, and especially if you have new diagnostic tests being developed, this is a really important thing. But also, as I mentioned a bit earlier, there's always new platforms being developed. There's always new sample types being developed. You think about all the different rapid diagnostic tests that happened during COVID, or all the different PCR places, or all the expanded so rapidly, right? And this idea that all of that was being done at quality needed to be backed up with actual testing, right? You need to guarantee that quality. And so this is a really important idea, and I'll talk about it. Trainings and webinars, quite obvious. This is just a kind of a list of some of the trainings that we've done over the years. But this idea of quality assessment and training and capacity building all kind of fits together, right? Ideally, if you're assessing quality of the laboratories, if there is maybe a laboratory that isn't performing well, then that feeds into the training cycle, and that feeds into the capacity building, and hopefully you can fix the problem. So a bit, some of the experiences from these networks. So the Emerging Viral Disease Lab Network has been a thing in Europe. It's a European funded program. It's been around in a various state or different names, but different laboratories, but it's kind of existed for about 20 to 30 years. We've coordinated it for the past 6 approximately, or 7. And that was around when COVID happened. What's interesting is it did function quite well, right? It really did its job. It just kind of got overwhelmed, right? Like everything else did. No one was really prepared for the number of samples or the number of cases or things like that. But a couple of things that are interesting, and I think important to highlight with regard to this network. So this was made up of a bunch of different laboratories in a bunch of different countries in the EU. Some of these people had coronavirus expertise, right? Some of these had been studying coronaviruses for many, many years. So when the first sequence was published, there was a group in Berlin that almost took about 2 days, and they made a diagnostic test, right? So it's very fast. Yeah, and that's something that's really possible. I mean, with open and we'll say good faith sharing of diagnostic or of these sequences for these pathogens, the lab portion often here is not the hard part, right? It's the sharing of those sequences that's way more problematic than actually developing the diagnostic test. So they did that very quickly. They also had access to other coronavirus samples in their banks and in their libraries, whether it was the MERS, Middle Eastern Respiratory Syndrome virus from camels or from human patients, or SARS-1 from 26 years ago now, or whatever it was. So they were also able to then quickly kind of assess within a day or a couple of days, if their assay was working properly. And then they were also able to ship that assay, that diagnostic test, and a panel to test on to all these other labs within Europe. And so most of the European laboratories were able to do testing sometime around, that 16th, 17th, 18th area of January, which is about 5 or 6 days after the sequence was uploaded, right? That's very fast. So the system worked very well that way. And most of these countries had diagnostic testing in place and good quality diagnostic testing before the first case in Europe. And that's really, really crucial. It fell apart quickly after that, right? But the idea that you could identify and have a working diagnostic test distributed through all these countries was really impressive, because that's not how it worked here. That response fell apart multiple ways very quickly. And that's kind of just a little bit of luck, but there's a little bit of history there too, because it goes back to the 2009 flu pandemic. That was a fairly large pandemic. It was global. There were a lot of cases, and what's interesting about this is the U.S. and specifically the Netherlands both did things a bit differently, and that kind of affected future things, right? So the U.S., when the 2009 flu pandemic happened, CDC said, we'll make a diagnostic test, we'll make a PCR test, and we'll distribute that to all the laboratories in the US and also many, many laboratories globally, right? The CDC has a big, it's the IRR, it's the International Reagent Reference Library, something like that. They share, or they provide these diagnostic tests to many, many countries and laboratories for little or no charge. That's been something they've done for a long time. They did it with influenza, Ebola. They do it for a lot of, some of the mosquito viruses. They do it for a lot of stuff. What happened in 2009 was they made a really nice PCR test for the 2009 influenza and distributed it to all the labs in the US. And it worked really well. Worked well globally, worked well in the US. There wasn't that many cases, right? And it wasn't that difficult of an assay to design. So the US learned that works. The Netherlands did things differently, and a little bit of that has to just do with legal government structure. There's a lot of independent hospitals and laboratories in the Netherlands, and so they all developed their own PCR tests for the 2009 influenza outbreak. And what the national laboratory did was just to do an EQA, to do a quality check and say that they're all working, right? So they were all very different, but they all turned out to work very well and had good quality. And so that system, what the Netherlands learned from the 2009 influenza pandemic, was decentralized, right? So we have a centralized idea and a decentralized idea. And both countries thought this works great. And then SARS-CoV-2 came, and both countries did the exact same thing. They went back, it's a respiratory virus. They went back to their 2009 playbook, and they did the same thing. And the interesting part of that is that in the case of the US, that fell apart quickly, right? Because there were just too many tests. There were too many samples. It was too big. And there were a few mistakes made with the design, and there was a few mistakes made with the manufacturing. And therefore, testing in the US was 2 months behind. Ultimately, it didn't matter that much, right? Because it just got so big. But if you start thinking about a 2-month window for a new emerging pathogen or a rare pathogen, that's pretty serious. And so these are two really interesting different ideas, right? One is to decentralize. Everybody can design their own assay and then follow up with a quality check to see if everything works. Or the centralized idea where you just go big and send it one kit to everybody. And I think that little twist of fate is kind of an interesting idea. And I think it's worth thinking about for future outbreaks. This is a completely different laboratory network, but also I think really important ideas kind of learned from this. So post-COVID, right, we had, I don't know how many of you remember, there was a season of the triple-demic. There was a lot of news on a triple-demic, right? It was respiratory syncytial virus, influenza, and COVID. There was such a big emphasis on testing for respiratory diseases, right? I mean, you have to differentiate. If somebody walks in, you have to be able to tell if it's COVID or influenza or RSV or whatever. So this, especially testing for respiratory syncytial virus, really scaled up also post-COVID. At the same time, there were a number of vaccines and monoclonal antibodies that were being developed for the elderly and newborns, which are your two most susceptible risk groups for RSV. So there was a need to really scale diagnostics. And so there were a lot of new manufacturers, a lot of new platforms, had to double check all the quality. So that was something that needed to be done. The other thing that was of importance was you needed to really scale sequencing and bioinformatics, because in order to check if your monoclonal antibodies are still working or your vaccines are still working, right? You can imagine you've never really had a working vaccine for this, and all of a sudden you go in and vaccinate all these newborns, and the virus just shifts a little bit, as these respiratory viruses sometimes do. You needed to scale sequencing to be able to really follow all the efficacy and the outcomes from large-scale countrywide vaccination and monoclonal antibody treatment programs. This was a really nice EU project that did a lot of that, and it has been very productive so far. The vaccines have been implemented in most of the countries now, as well as the monoclonal antibodies for newborns, and so far not a lot of antiviral resistance or change yet, but there are really nice monitoring networks in place. And I threw virus in here too, just as a strange mosquito diseases. This is one of those. This is a bit like West Nile or Zika or some of these other viruses. We've known about these viruses since like the 50s, 40s in some cases, right? We've known about them for a very, very long time. Many of them are either discovered in a forest in Uganda or a forest in Brazil, right? Those are kind of the two main places where these were all discovered. And sometimes they just circulate around the globe. Chikungunya is a great example. Zika is a great example. West Nile in 1999. And they find a way to have these cycles of a sort. Some become endemic in a way, or change the environment, or change their prevalence, but this was kind of a new situation, and Oropouche is a bit interesting because different but similar to influenza. It is a segmented virus, so it's not as many segments as influenza, and it mutates a little differently. But it is segmented, and so you can swap pieces, and that sometimes leads to it expanding across the globe, and that's what happened here. But again, because of these networks that were in place, and because of the funding, and because of the legal stuff, and all these other things that make up these robust networks, we had a vial of this sitting in the basement in a glass container from the 60s, roughly. And so when this first started to happen, you first started to get alerts from Brazil and from Cuba, no one in Europe had a test for this, right? This has never been in Europe, right? This has never been a thing. The mosquitoes aren't there, the virus isn't there. But because you started to see these signals, and you started to see infections in Brazil and Cuba and some of the other South American and Central American countries, and there is a history of colonialization with the Netherlands. They have islands still, Aruba Bonaire and Curacao and St. Martin. There's a lot of tourists. Apparently the Italians love to go to Cuba. And so you started to prepare for this idea that like, well, of course, there's going to be some cases introduced here. What do we need? And so because we found a vial in our basement and our one weird, strange collection we had, we were able to very quickly, you know, with the help of our very friendly biosafety officers and legal team, grow this up and provide positive control material to all the labs, provide guidance on diagnostic test development. We're probably a couple months away from publishing the quality assessment paper in Eurosurveillance. So we were able to test quality as well. And so very quickly, most of your country, most of your national laboratories within the EU had capacity to test for this very rare in Europe virus. And it turned out that number may have increased since I put this together, but then they were able to detect import cases from travelers and things like that and to follow up. And that's not so many cases, right? 19 cases, not so scary, but if 19 becomes 19,000, you know, then this becomes a much more important concept, being able to scale these diagnostics quickly and with quality. So I just want to go back. I think this was a guidance document or a little checklist from the CDC and maybe the Wisconsin Public Health group. I have all the references in the back of the PowerPoint, but just again, this idea of you know, efficiently building these laboratory networks at the different levels, both vertically and horizontally, and really using that as an idea, not only for the technical side, right, for the preparedness and response to these pathogens, but also as a kind of an idea of you know, resiliency or robustness, right? They can be more efficient. They don't require the same intensity level of funding, and they're a little more robust when it comes to the boom and bust cycles of public health and research funding. And with that, I'll just acknowledge you know, the NDSU Public Health Department and the advisory board. Very much appreciate having me back to talk to all of you and to walk around campus on homecoming week. And kind of leave you with the idea that the networks are about people and systems all over the world. These are a couple of nice scrapbook photos from traveling around and meeting a lot of cool people. I always put a reading list on in case everybody wants to, you know, read all the good stuff that I'm interested in. And with that, I will take questions.
You go back to
I'll read the reading list up, certainly.
Well, thank you. We'll take a question. All right, speak up next month.
Manuel Nojang. One of your slides, you said that plants are useless. Planning process is what's important. So before that, you mentioned all the dismantling, budget cuts that is happening across the globe, being a catalyst of what is happening within the United States of America. So my question is, you are in this field, how prepared do the labs have the capacity to prepare for the next novel virus that's going to pop up? Or is it time for us to change planets?
Yeah, that's a big question. Yeah, so one of the reasons I like there's another version of that. Plans are useless, but planning is essential, and it's kind of like some models are or all models are useless, but some models are helpful. Or, you know, there's variations of this kind of idea in a couple of places, but I always like it because I think if you work in the public health field, you work in a hospital, you work in biosafety, biosecurity, you work, you have a million of these meetings and everyone has a response plan and a preparedness plan and this plan and this plan and all these documents. And that's good. We should all do that. But we all realize now, I think, that those don't really actually help that much, right? Like you still have to do stuff and you still have to have the people to do stuff and you still have to have the money to do stuff. And how do you do that stuff, right? And how do you lay those foundations, right? How do you get around legally sample sharing between countries, data sharing, patient safety, patient data, all that stuff? Those are always problems. Every single time they're problems, right? And so how do you get those problems worked out so that you can actually do the technical work of responding and stuff like that? I don't know. I suspect, I mean, you're pulling so much money out of the system globally, right? I don't know what the final number is going to look like. I don't know how many people that's going to be. It's going to be messy. On the other hand, we have learned a lot of things. I mean, you know, the post-Ebola, right? Everyone responded to Ebola. Like every country sent a lab, every country sent teams. People got a lot of experience from that outbreak. And that sort of coincided with technological advances, sequencing and better, faster PCR development, all these open platforms for sharing of sequences and protocols and things like that. And so when SARS-CoV-2 happened, many of the laboratories that we in the United States and Europe worry about being able to function had the technological expertise, no problem, right? What they didn't have was the money and some of the public health, you know, sample referral, patient referral, enough physicians, those type of things. That's just kind of an all the time problem. And I don't know that there's a fast solution to that. But if I could, you know, snap my fingers and redirect some money, right, it would be a lot less focus on sequencing 1,000,000 trillion samples and maybe hire a few more nurses and doctors. But that's to be determined, I guess.
I'll go.
Tell who you are.
Oh, my name is Zach. I don't want to stand up. Is that okay? Okay. I'm from the safety office here at NDSU. One of our responsibilities is biosafety. And you have been all over the world, and I'm interested in your perspective on how biosafety is emphasized in different places, or just anything interesting with biosafety.
That's a good question. So it is highly variable. CDC was, so US CDC was pretty intense, right? It was, and it's changing too, I think, quite dramatically post-COVID. Europe's tricky. I think the Netherlands in general is they're quite practical about things. So it's been quite easy to work there. But the problem is different countries have different, the EU sort of covers broadly all the rules, but there's like little twists with every country, right? So I think France has a weird rule where there's a certain amount of DNA that you can't send, and it's a really low amount. So that always causes problems. But in general, that's a really interesting question. Also, because I don't know, there was recently, it was with the new biosafety manual, the last version of the BMDL or whatever it was, kind of went away from all the BSL-3, BSL-4, right? It was all like risk assessment based and kind of local regional based, right? That's very interesting, right? I from a lab side, so we are naturally are in conflict.
Said privacy, people like tell your eyes like.
Yes, yes. There's like an inherent conflict that's just built in, which all in good fun usually. But I think that approach is it's complicated, right? I think it's overall from my side, from the lab side, I think it's probably very useful, but it's very easy to see from a biosafety security standpoint that when you have uneven application across the globe, that's probably going to cause problems somewhere down the line, right? So it's a tricky situation, and it's it's almost lab by lab. I mean, and sort of to broadly apply some of these things is really complicated. I don't have a picture. So our Ebola lab that we set up, CDC, when they first started the laboratory in West Africa, it was at a hospital. And it was highly unsafe. And so they moved quite quickly after that. They found it was meant to be a housing development, like a social housing development that was being built about 3 hours outside the capital city. So it was quite rural. And they had only built 10 or 15 of the houses that maybe, and I think they were planning on building maybe 100 or something like that, but it had stopped quite quickly because of the outbreak. But the houses were perfect, right? They had a bathroom, 2 bedrooms in the back that were 12 feet by 12 feet, and then kind of a main one bigger central room. And so purchased those, and Doctors Without Borders, Médecins Sans Frontières also purchased some because they were running the treatment unit, and used those for laboratory and office space. But that was just the extraction and PCR labs and things like that. The hot lab is where we did all the sample inactivation and all the really nasty stuff in the suits. It was really just 4 2x4s and some plastic tarp and a tin roof, right? And it was open. I mean, and it was, you used a lot of bleach and a lot of microchem and things like that, but that was the safest way to do that work, which probably breaks just about every rule that, if you start to apply some of the standards, it doesn't work. It was the same with some of the Lassa fever labs too that we built in Liberia. If you're lucky, you have a functional glove box, but oftentimes you're not that lucky. And then you start talking about power cuts and things like that. And there's all kinds of some wastewater treatment. Like it gets very complicated very quickly. But that's always an interesting discussion. I think that broad application is also challenging. That's also one of the things though too, right? Like when I start complaining about admin, I also mean biosafety and biosecurity too, because that can really trip some of this stuff up. And it's not, I know it's intended, like I said, it's all in good fun in some ways, and we need these things. But if you don't have these, if you don't have your safety plans worked out and your risk assessments done and all these check boxes done before the thing happens, it's going to take way too much time to get through all that as this outbreak or as this event is happening. And that causes a lot of problems. So it's really necessary for these networks to think about all that and to have these plans in place first before the thing happens so that you can go fast when it does. Yeah.
We'll bring it back home. So the state of North Dakota is going to open a brand new state lab, $70 million, opening next June.
Are you recruiting?
I'm asking.
No, probably not. It's probably not. No.
So 2-part question. If you were running it, what would be a couple things you would cast as vision? And then second question is, a bunch of students here, what job opportunities might these students be thinking about if they were to pursue a pathway like you have, not necessarily go to the Netherlands, but how do you pursue a job in public health? So two parts, vision for the new state lab, and then some encouragement to students.
That's a good question. So, I mean, it clearly I'm biased, but I think you reach out to your regional partners, right? Like, I mean, I think I've been away for a long time. So I don't know exactly how connected and how many of these systems these state labs have in place with each other, but that would be a priority. I mean, like I said, not every lab needs to be able to diagnose Ebola, right? But you know, there's common issues here like West Nile and some of the tick and mosquito, and there's plenty of livestock, zoonotic possibilities. There's a lot of discussion around zoonotic influenza. There's all kinds of possibilities, but also every now and then we get one of these global events that does also affect just about every possible place. So seeing where your regional partner capacity and strengths and weaknesses and all that type of stuff would be a big priority. And then you just fill holes, right? Then you just fill gaps, you know, and however much funding and personnel and staff and stuff you have to do that, that's how much you do. I guess you could say that there's probably an advocacy component in there too, but I'm not very good at that. So maybe I'd let somebody else do that. Students. Well, I'm a lab guy, right? So I've always been a lab guy. So I'm, again, a bit biased that way. But after I finished my PhD, I ran away from academia as fast as I could. I didn't want to do a postdoc. I wanted nothing to do with it. So I was teaching. I taught at a community college for microbiology and things like that for a little while, and that was really nice. And I also volunteered at the Chicago Public Health Department. It's a weird story. It's a lot of weird. I didn't get an MPH. I did a master's degree in the School of Public Health, but I never got an MPH. But I took all the classes pretty much, but I had a lab focus, right? It was this weird sort of thing that Pittsburgh did. But I took all the biostats and all the, you know, epidemiology, outbreak type stuff. And I kind of wanted to get back into that a little bit more. So I had a nice volunteer position at the Chicago Public Health Department. And I got in on 2 different outbreak investigations. There was a Legionnaires outbreak that happened in like a hotel fountain. I think ended up 1 or 2 people died. One was international. There's a thing. But that was just a really nice basic investigation. And then there was also a bigger national, I forget exactly what the detail was. It was like a pain injection situation. There was like a compounding facility, and it was like a fungal contamination in a pain injection medication or something like that. And that caused a lot of problems. It was, I don't remember, it was a lot in the Midwest, but I do think it was national. And that was just, again, a really nice, you know, very community public health epi type investigation, and nothing to do with labs, completely different. But working, you know, that having the lab background and then having a little bit of that public health background, it was really nice. For Milwaukee first, because that was very city, municipality public health. So you had those outbreak investigations and the epi component. And then later at CDC too, I did more of the lab stuff at CDC, but it was also a lot of small outbreak investigation type epi work too, which was really nice. So it's always beneficial to have both, you know, the more options, the better.
Well, thank you for what you're doing to support the program and the advisory board, as a donor as well, you know, and let's give Dr. Presser a round of we cannot confer on you a Master of Public Health degree.
All right.
We can give you 2 stickers for your computer.
Even better.
Say, I love NDSU Public Health.
Perfect.
But you can add more to your NDSU here. Thank you so much for being here. Thank you everyone for attending.